Okay, so on to the next disease, cystic fibrosis, right? So cystic fibrosis is an inherited condition, and it's inherited in an autosomal recessive way, meaning both of your parents need to have the trait for cystic fibrosis, and then you need to acquire both alleles uh, to have cystic fibrosis. Okay, and this is excessive and abnormal secretions in the respiratory tract. It can happen also in the pancreas and the gastrointestinal tract, where you have thick secretions that block up the ducts in these organs. So in the airway, it leads to airway obstruction. It leads to a chronic cough, chronic mucus production, and recurrent lung infections. So patients with cystic fibrosis unfortunately get recurrent lung infections, one pneumonia after the other, because they have abnormal secretions into their airway, okay, which blocks up their airways with thick mucus. So as I mentioned, the mucus production can also occur in the pancreas and result in blockage of the pancreatic ducts that are trying to send digestive enzymes into the gastrointestinal tract to absorb nutrients, right? So without those pancreatic enzymes, you're going to have difficulty absorbing or breaking down nutrients such as carbohydrates and fats and proteins, and that's going to result in malabsorption. And if you don't absorb nutrients from your gastrointestinal tract, that's going to result in weight loss. Okay, so it's not only a respiratory problem, it's also a pancreatic problem, and patients can develop pancreatic failure, and they're not able to produce those digestive enzymes. So often patients with cystic fibrosis actually have to take pancreatic enzyme replacement, okay, so that they can digest the nutrients that they're eating. Okay, so the image on the right is showing you a normal airway, and at the bottom it's showing you an airway with cystic fibrosis, where it has these very thick, sticky secretions. And often with the inflammation, there's blood within the mucus, and that's a perfect place to get bacterial infections. And the secretions are very hard to clear. So patients with cystic fibrosis often need respiratory physiotherapy, a lot of proper respiratory precautions to avoid getting a pneumonia. Okay, so what's the long-term treatment for cystic fibrosis in terms of the lung condition? Well, they often require repeated courses of antibiotics, mucolytics to try and break up that thick sputum, and bronchodilators such as albuterol to try and bronchodilate, so that at least you can try and cough up that thick sputum. Okay, and as I mentioned, in terms of the pancreas, they often need pancreatic enzyme replacement. Okay, we're almost there. So let's discuss some other conditions involving the lung. So pleurisy or pleuritis is just inflammation of that very sensitive lining around both lungs, right? So if you look at the image and ignore the collapsed lung for now, just look at the other lung. That blue lining all around it, we could call the pleura, okay? And the pleura is almost like a saran wrap around each lung. and it keeps the lung adhered to the inner chest wall. Okay, so when the chest wall expands, the lung goes with it. So if you get inflammation of the pleura, it's going to be very painful when you take a breath in, because you're stretching the pleura, right? And we call that pleurisy. And because it hurts so much to take a deep breath in, it results in shortness of breath because you're taking shallow breaths because it's so painful. It can cause chest pain at the area because the pleura is being stretched and it's inflamed, so very painful at a certain area of your chest where you have the pleurisy. And sometimes when we listen and we get people to take big breaths, we can hear a friction rub where the pleura is sliding over itself, because there's two layers to the pleura. There's the parietal pleura and the visceral pleura. And when you have pleuritis with lots of inflammation, you can hear a friction rub where the two pleura are sliding over each other while they're inflamed. A pleural effusion is a collection of fluid in the pleural space. So not in the lung, but in the pleural space or the thoracic cavity. Okay? So a pleural effusion is going to actually move the lung out of the way because there's fluid building up within the thoracic cavity itself. A collapsed lung is called a pneumothorax, right? So in the image there, you can see that the lung has collapsed. It's peeled away from the inner chest wall, and it's recoiled as much as it wants, and it becomes almost like a little bunched up fist, right? That's a pneumothorax. A hemothorax is a collection of blood in the thoracic cavity, and that commonly occurs with car accidents or some kind of significant chest trauma, where now you've injured blood vessels and a portion of the chest cavity has filled with blood, moving the lung out of the way again. So it's similar to a pleural effusion, except it's blood that's filling the cavity. A pulmonary contusion, again, from some kind of an accident or injury to the chest wall that has now bruised the lung behind it. Okay? So it's a direct bruise on the lung. Let's talk about a tension pneumothorax. So if we look at the image, we see that lung has collapsed. Okay? And if it's just collapsed and there's no pressure in the air that's around the collapsed lung, we just call it a simple pneumothorax. What happens if that air that's surrounding that collapsed lung develops higher and higher pressures within it? And that can occur because the lung that's collapsed because it has a little hole in it. So when you take a breath, a bit more air from your breath goes into that open cavity that's filled with air, and it acts like a ball valve. So when you inhale, a bit more air goes into that air cavity, and then you inhale again, a bit more air goes in to that empty cavity there you see in the image, and the pressure builds and builds and builds until you develop what's called a tension pneumothorax. So a tension pneumothorax is where that air around the collapsed lung is now under high air pressures, and that is going to be an emergency. So what's going to happen is that air that's under pressure is going to push everything over to the other side of the thoracic cavity and even start to compress the normal lung. So it's going to move the trachea over, it's going to move the heart over, and it's going to now start to squash the normal lung. Okay, so let's look at the symptoms of a tension pneumothorax. Shortness of breath. Well, you've collapsed one lung, you're likely going to be short of breath, but now with a tension pneumothorax, you're moving everything over to the other side of the thoracic cavity. Chest pain, for sure, because the collapsed lung peeled away from the inner chest wall, so there's chest pain. Increased heart rate and respiratory rate. Well, if you're now pushing everything over to the normal side, you're going to start to breathe faster and faster because you're running out of normal lung to breathe into. So your respiratory rate is going to increase. But it's also compressing the heart and all the blood vessels that are returning to the chest cavity, the thoracic cavity. Okay? So you're going to develop hypotension because the veins can't return the blood back to the heart. The inferior and superior vena cava are unable to return blood to the right side of the heart because the pressure is so high in the chest cavity. Okay? So you develop severe hypotension, and that results in tachycardia because the heart is saying, I'm not getting any blood, so I'm not able to pump blood out to maintain my blood pressure. I'm going to beat faster and faster and faster to try and maintain some kind of a blood pressure. The trachea deviates to the opposite side because the high air pressure on the collapsed lung side is pushing it over. So you get tracheal deviation. You have absent breath sounds on the affected side, right? So where the pneumothorax has occurred is where you're going to have absent or decreased breath sounds. And finally, you have distended neck veins. Why? Well, because the blood cannot return into the chest cavity due to the high pressures in the chest cavity from a tension pneumothorax. Okay? I hope that makes sense. If it doesn't, we can again review this in a tutorial so that it makes complete sense. Okay, so let's look at these two images to try and solidify this information. So in a simple pneumothorax, let's just look at the image on the left to start with. In a simple pneumothorax, the lung has just collapsed, and the air around it in the pleural space is not under any pressure. So you may be short of breath with a simple pneumothorax because one of your lungs has collapsed, but there's no pressure in the air around the lung, so it's not going to push anything over to the affected lung, the unaffected lung, sorry. So you're going to have chest pain in a simple pneumothorax because the lung peeled away from the pleura, from the inner thoracic cavity. You're going to be short of breath when you take a breath, but your other vital signs are typically going to stay all right. Okay, let's look at a tension pneumothorax. So a simple pneumothorax that now has some air that can go through the affected lung and into the pleural cavity. And every time you take a breath, you add a bit more pressure to the pleural space around the collapsed lung. And it builds pressure and builds pressure with each breath. And now everything starts to shift over to the unaffected side. So you're compressing your heart. You're compressing the normal lung. You're shifting your trachea over to that side. You're blocking all blood flow from returning to the thoracic cavity, i.e. the heart. So you'll have distended neck veins, tracheal deviation, absent breath sounds on the affected side where the pneumothorax is. Okay, so I hope that makes sense. Again, we can review any of this in a tutorial. Okay, what about chest trauma? So you're on your bike and not paying any attention, and you drive your bike into the back of a car that's parked. So I gave that example because that's what I did when I was about 12 years old. Okay, and I flipped over the top of the car and fractured some ribs. All because I wasn't paying attention. Okay, so rib fractures can be single rib fractures, which will be painful, especially when you take a breath or you move. They'll be painful, but typically they just heal after 4 to 6 weeks. There's nothing else to do except take pain medications and making sure that you're taking deep breaths. Sometimes we supply patients with an incentive spirometer to remind them every hour or two to take deep breaths. Okay? If you have multiple rib fractures, say 3 or 4 or 5, well, that's going to be extremely painful. It's going to be very difficult to take normal breaths. And when you don't take normal breaths and ventilate the alveoli start to collapse, right? In the poorly ventilated area, and you develop atelectasis. And when you develop atelectasis, those collapsed alveoli, that's a perfect place for infection to start, leading to a pneumonia. That's why in older patients in particular, we really try to control their pain, and we give them an incentive spirometer to stop them from developing atelectasis that then leads to a pneumonia. Okay? What about a flail chest? So a flail chest is where the ribs are broken at 2 sites. So each individual rib is broken at 2 sites. So say you have 4 ribs that are fractured, such as in this image, and each rib is fractured at 2 sites. Okay, that's basically a loose segment. It's not really connected to the chest wall anymore. So we call it a flail segment. So when you take a breath in, that segment that's loose is going to go inwards. So when you take a big breath and inhale, that segment that's loose is going to suck in. Okay? So a flail segment can really impede ventilation, because when you take a big breath, you're supposed to have your entire chest wall expand, and with that, your lungs expand with it. But what can happen with a flail chest is a large segment that's now loose goes inward with each breath, and it makes it very difficult for the lung to fully expand. Okay, so it can result in decreased ability to ventilate the alveoli. Okay, and in a severe flail chest, like a massive segment, has 2 fractures of each rib at multiple rib sites, and it's such a large segment that when the person takes a big breath, the lung just can't even expand on that side because the whole segment just goes inwards instead. Okay, so it can really impede ventilation, and if someone can't maintain ventilation, then they'll need to be intubated, right? So if you have a small flail chest segment, we'll treat it with painkillers, and we'll just let it heal. Okay, because it will heal. But if it's a big flail chest segment that's making it difficult for your lung to expand on one side, then sometimes that person needs to be ventilated because they just can't breathe on their own. Okay, so I think this is going to redirect you to YouTube to see a flail chest segment. It's definitely worth watching though, okay? Notice when the person's taking a breath in, a segment of their chest wall collapses inwards, okay? So with inspiration, the flailed chest segment goes inwards. And you can imagine that that makes it very hard for that lung to expand. Because instead of the lung expanding on that side, a portion of the chest wall is just being sucked inwards. Okay, so it impairs ventilation. And someone who's breathing very hard and trying to maintain ventilation for hours like that will finally go into respiratory failure. And that's why they need to be intubated, because they just can't maintain normal ventilation. Okay, so let's go on to another condition that's called ARDS, Acute Respiratory Distress Syndrome. And ARDS can occur from a direct lung injury, such as a patient that's had chest trauma in a car accident, but it can also occur from a significant illness somewhere else in the body, such as sepsis, or a severe inflammatory condition, such as, say, pancreatitis. So it doesn't have to be from lung injury itself, like a direct impact, but it can be. And what happens in this condition is a lot of chemicals are released when there's an injury to the chest wall, say, or say to another organ, such as the pancreas. And there's tremendous inflammation that gets released into the bloodstream. And if you remember the inflammatory process, there's a lot of histamine, there's a lot of chemical mediators that are released, and they cause capillaries to become leaky all over the body. And when capillaries become leaky in the lungs, they leak their fluid into the alveolar space. And the alveoli start to fill with fluid. And that impairs gas exchange. And when you impair gas exchange, you retain CO2 and you become hypoxemic. Now, as the lungs fill with fluid, or the alveoli fill with fluid, they become very non-compliant, right? It's really hard to inhale and to expand the lungs because the surfactant is being affected with all this fluid that's around. So it impairs ventilation to expand the lungs, and it also impairs oxygenation, since oxygen and CO2 can't get across the alveolar membrane due to all this fluid. So ARDS is a ventilation problem because the lungs have become very stiff and non-compliant, and it's an oxygenation problem. So let me give you an example. A patient comes in and they're severely burned in a house fire. And there's a lot of inflammation taking place in the tissue of the skin. And that inflammation releases a tremendous amount of histamine and other inflammatory markers into the circulation and causes this exact picture, ARDS, from all the vasodilation and release of fluid into the alveoli. So it doesn't have to necessarily be from a lung injury. I mentioned pancreatitis, burns, anywhere where there's massive amounts of inflammation. Okay? And if the hypoxia worsens because all the alveoli are filling with fluid, what happens to the patient? Well, they start to get restless, they start to get short of breath, and now they're becoming hypoxic and high CO2 levels, hypercapnic, and now they're starting to become fatigued from the high CO2 levels, reduced level of consciousness. The hypotension and tachycardia are occurring because the blood isn't being oxygenated, so the heart is trying to pump faster and faster and faster to try and get some oxygenation of the blood. The urine output decreases because all the fluid in the vascular space is leaking into all the different organs and tissues of the body. Okay, so reduced urine output, which is going to cause acidosis. Why? Well, the kidneys aren't being perfused because of the hypotension, so that's a metabolic acidosis. The lungs can't clear CO2, so that's going to cause a respiratory acidosis. And finally, when the patient is so hypoxemic, so low oxygen in the blood, and hypercapnic, high CO2 levels in the blood, they lead to really deadly arrhythmias such as ventricular fibrillation, and finally respiratory and cardiac arrest. So often these patients need to be intubated and put on a mechanical ventilator. Okay, so this whole syndrome occurred because of massive release of inflammation markers and mediators into the bloodstream from either a direct chest injury or another condition such as burns or pancreatitis that have released inflammatory mediators into the bloodstream. Okay, so this next topic, pneumoconiosis. So really this is lung disease from having inhaled chemicals or particles, typically in a workplace. Okay, so when we refer to pneumoconiosis, we may be talking about having inhaled asbestos or silicon, which causes silicosis. Asbestos causes asbestosis. There's another one called coal workers' lung, where they've inhaled large amounts of debris from the coal. Okay, and when you inhale, whether it's asbestos or silicone or coal, it leads to inflammation, scarring, and pulmonary fibrosis. The lungs just start to fibrose and become very, very stiff, and the airways become filled with mucus and they start to obstruct, right? So in this image, really the lung should look pink, right? This one's all black and scarred and very abnormal image here of someone who likely worked in a factory where they inhaled asbestos or silicone or coal miner's lung, or in a coal mine. Okay, so really the focus here, if you're working in that environment, is personal protective equipment, right? So proper masks that stop the inhalation of these particles into the lung. Okay, we're almost done. Just a quick slide on COVID-19. So as you probably know already, the majority of people that develop or acquire the virus COVID-19 really don't have any significant complications, right? They're either asymptomatic or they develop upper respiratory tract type infections such as a runny nose, a cold, or a cough, right? Because it's really just a coronavirus. And other common colds are coronaviruses. And that's the difficulty, trying to differentiate who has just a common cold and who has COVID-19. Now, COVID-19, this particular strain of coronavirus, can get into the lung and lead to a pneumonia, okay? So a viral pneumonia, not treated with antibiotics, but it can set up incredible amounts of inflammation. So that's your own body responding to the virus, causing tremendous amounts of inflammation within the lung. And that's how patients end up in the ICU, because they have so much inflammation that the body's producing to fight this virus that their lungs fill with fluid. They develop ARDS, right? Acute respiratory distress syndrome. They can't oxygenate anymore, and they become profoundly hypoxemic. And they end up on a mechanical ventilator because they can't maintain their oxygenation. Okay, and we know that when patients with COVID-19 end up on a ventilator, they run into many more complications and often end up dying. Okay, so part of it is this virus getting into the lung causing a viral pneumonia, and part of it is this intense inflammatory response that some patients develop against the virus. Not everyone, and that's why some patients do just fine with it, and others develop ARDS. And finally, after all this inflammation has occurred for weeks, patients can be left with injured lungs, right? Fibrosis in the lungs, because there was so much inflammation that took place during the acute infection. And so we're finding a lot of patients are left with scarring of their lungs. They have chronic shortness of breath, chronic fatigue because of the lung injury that occurred. Okay, last slide. I do apologize for this being much longer. There happens to be a lot of information in this module, and my suggestion would be to mark down the topics that don't make any sense or are confusing. Mark them down on a piece of paper and bring them to tutorials so that they do make sense, right? So I think that's an important part of self-study or homework, is to mark down the information that isn't completely clear in your mind, and then it can get clarified. Okay, so this question, a 15-year-old complains of feeling tired during exercise and has exertional dyspnea, meaning when he goes for a walk or runs, he gets short of breath. Okay, what condition is the patient likely experiencing? So he's 15 years old, so he's feeling tired with exercise and he gets exertional dyspnea. Spontaneous pneumothorax. Well, if your lung separates from your chest wall and it collapses into a little ball, that's going to hurt a lot. So it's going to be sudden, right? Suddenly the lung collapses. You're going to be short of breath, and you're going to have inspiratory chest pain, or what's called pleuritic chest pain. Okay, so it's not going to be that one. Pulmonary hypertension. Well, pulmonary hypertension is more of a finding than a diagnosis. Pulmonary hypertension just means you have high blood pressure in your pulmonary artery, and there would be no reason for a 15-year-old to have pulmonary hypertension. Remember, pulmonary hypertension can develop from COPD. It can develop from having had multiple pulmonary emboli that are blocking the arteries. So unlikely for a 15-year-old to have that. Exercise-induced asthma. Well, there's the one. A very common condition where you can often feel tired during exercise because you're breathing faster, you're working harder to breathe, and when he goes to exert himself, he gets short of breath. So exercise-induced asthma is the answer. Cystic fibrosis, the description would be more along the terms of increased sputum production since being a young child, chronic cough, losing weight from malabsorption due to lack of pancreatic enzymes. So cystic fibrosis doesn't fit that description. Okay, this module is done. Again, I'm sorry for the length of time that it took.